Welcome to the Voyage Clinics podcast. I'm Dr. John, your host, and I'm here with Dr. John Edwards, and we're going to talk about neurosurgery. So, as you know, the objective of our podcast is to bring, light and knowledge to our community about medicine and about healthcare. And so, pretty awesome opportunity to talk to a neurosurgeon. So, Dr. Edwards, tell us a little bit about you. Where you grew up here in Provo, and where did you go to school? And tell us about your journey there.
I went to Provo High. So
Let's go.
I'm actually pretty boring, honestly. I went to BYU. I met my wife there. She's a nurse and was in nursing school when we met. And then we got married. About a year after we got married, we went off to medical school. We were just doing this drive the other day. We drove to Iowa, and we had a U-Haul with a trailer behind us with my wife's high school Oldsmobile on the trailer. And we were going up past Park City. And the U-Haul was just smoking like crazy and going about 25 miles an hour. And I just had this feeling of all of our friends were getting jobs and making money. And it felt like we were going backwards and that everybody was just zooming by us. And so there's this moment when the reality of a commitment to go to medical school and residency after that became right in front of us. But it's been a good journey. Grateful that we did it. We went to Iowa for 4 years. Residency for me in neurosurgery was 6 years. All of the programs are 7 now, and they include a little bit more research. And I was in Indiana for residency. My residency program, I loved medical school. Iowa was fantastic. And then the residency program was awesome. It was a little bit different than some neurosurgery programs that maybe are a bit militant or pretty rough. Our program had a very good culture. All of the neurosurgeons were great people. And there were about 25 to 30 neurosurgeons in the program. And about 8,000 surgeries were performed on a yearly basis. So it just gave us this great clinical opportunity to be learning and absorbing all of this experience. And then after residency, I ended up coming back to this community to practice and have been here for almost a decade, which is crazy. Yeah.
That's really cool.
That's me.
What a fun journey. 6 years of residency, that's a grind. Mm-hmm. Family medicine is 3 years post.
I should have done family medicine.
It's lovely. But it's funny. Like, it sounds like the culture where you trained was really unique as far as neurosurgery. The typical stereotype is like neurosurgeons are jerks, right? And so,
yeah, it's true.
I don't get that at all from you, and neither do my patients. My patients love you, by the way.
Oh, that's good.
I've referred several to you over the years, and that's unique. That's really cool. Mm-hmm. That's really cool. What a cool, just a different culture. It does come from the residency training folks, I think. Like it comes from the culture there.
One of our chairmen, when I first started residency, really believed in fostering a good culture within the residency, and supported some activities and nice dinners and things that made a difference. Mm-hmm. And we've tried to do some of the same things in our practice. It is a lot of work. We have a lot of long hours, but we want to maintain good relationships with everyone and feel like a working environment where we all have good, close, healthy friendships is better for the patient care. So that's been an important part of our practice.
Yeah. Well, I resonate with that at Voyage Clinics. I started Voyage Clinics 7 years ago when I moved here from rural Moab. I was out there doing country medicine, delivering babies and working in the ER, doing the thing. It was fun. But I started Voyage Clinics because I wanted to be able to do that with my clients.
That's cool.
I'm from a small town. Connections with my patients is really important to me, and getting to know them, getting to know their families and stuff. And I'm with you. I think it allows you to be a better doc for them. Mm-hmm. Those connections and stuff. So that's really fun. Yeah, we operate separately. Like in order to do what we do, we kind of do like an annual membership, and we break it up monthly for folks, and it's reasonably affordable. So that was the difference between like Voyage clinics and like concierge medicine is like the reasonable, affordable part. And so that's kind of the backstory.
I like that model.
Yeah.
I think if people think about what they use car insurance for, you don't go to Jiffy Lube expecting Geico insurance to pay for your oil change. And we have to wrap our minds around the purpose of insurance. Taking care of yourself and working with a medical team for a lot of the prevention and maintenance kinds of things makes a lot of sense under that model.
Yeah.
And then hopefully you don't need some sort of major surgery, but if you did, that's where insurance can really be helpful.
Totally. And calibrating the American mind to that when they've been calibrated and conditioned in a different direction is kind of a challenge.
Yeah.
Most of our clients actually have insurance. And so,
right.
and so most families right now, what do they have? Like a $3,000 per person, $12,000 per family max out-of-pocket deductible. Total rubbish plan, right? Like it doesn't actually provide care to them. And
right.
So they love our practice. We have affordable, transparent pricing on across the board. And for like less than one person's deductible, we provide white glove access points to their family for the whole year. Yeah. As many visits, no copays, it's really fun.
I think that's a really, really good model. I think it would be hard to have a model like that in surgery because it's not the same kind of thing. But one thing about our healthcare system that is a major flaw is under an insurance-based healthcare system, nobody's really all that interested in prevention.
Yep.
And that's where all of the value comes, is it's way less expensive to prevent a problem than to treat it.
Yeah.
And so great model and great to have that close connection with patients and help them to stay healthy, basically.
Yeah, totally. We spend like 30 to 60 minutes with our clients. We get past the superficial healthcare piece. We go into prevention.
Awesome.
We have a built-in sleep coach program, health coach program. We do a lot of mental health. We do a ton of stuff.
Sounds like I need to sign up.
I've been working the equation for like 7 years, man. It's been really fun. Anyway, sorry for that little detraction from our main point, but it's fun to just kind of hear each other's stories and stuff. I want to hear just a little bit from you, Dr. Edwards, about neurosurgery, scope of practice. What do you guys do? You know, like I know it's brain and spine, and like, are there specific things that you can kind of speak to as far as like scope of practice and educate both, you know, my team and then my clients on those spaces? That'd be great.
Ultimately, I think one of our primary jobs is to understand when a patient would benefit from surgery and whether or not they require surgery. Is there another alternative strategy that would be better? Do they really need surgery? So that's probably the most important thing that we do.
Wow.
There's no surgery like no surgery, right? My brother coined that. And if we can recognize the patients that don't require surgery, that's a really important thing. It's also one of the harder conversations to have because oftentimes they've tried a bunch of other things. And one fallacy of thinking is if I've tried a bunch of things and my symptoms are still there, that means I need surgery, which is not accurate. We need to recognize when a patient needs surgery. And then the second part to the job is to perform surgery safely and as well as possible. And the third part is to take care of the patient's post-surgical problems or any other issues after we've treated them. And I think a final job that we have is to stay connected with a network of providers and caregivers in the community so that the patient's care isn't siloed to one particular subspecialty expertise, but they really have that whole network of people working with them. And we want to make sure that we're behaving well within that community and making it very easy for the patients to engage with their primary care doctors and physical therapists and chiropractors and others for the best overall outcome.
I love that. One of the things that I really value when I refer somebody to a surgeon is when they don't do surgery. And that sounds funny, but I really value that when they give me that feedback, and then the patient comes back to me, and then we keep working the equation. Mm-hmm. I think it speaks to just moral fortitude and being very ethical and really trying to do the right thing for the patient.
I try to ask myself, what would I recommend if this patient was my mom or my dad? And that's a pretty good litmus test. And sometimes there was a patient the other day when I looked at the imaging and I thought, I don't think surgery is needed. And the patient called back and said, I think it is. And so we had a conversation about that. And so sometimes the hardest recommendation to give somebody is, I don't think surgery is going to help you. But on the flip side, if we operate on patients that don't need it, then they have two problems now instead of one. Mm-hmm. Essentially, they have potential post-surgical issues. And if they don't have objective findings on their MRI scans, and we can't really accurately pinpoint a surgical problem, which is usually some sort of structural issue, they're usually not going to improve with surgery.
Yeah. Talk to us about the surgeries you do in the spine, in the back, and then maybe also on the brain. What are the common things that you see?
So everybody has some degree of degenerative spine issues. Every single patient on the planet after the age of probably 30 or 40.
I'm there. I'm 47.
47, yeah. And most of it's just like having a few wrinkles or some gray hairs. It's like just part of getting older. Doesn't mean you need surgery. It doesn't mean you need any aggressive treatment necessarily. Yeah. By and large, most of the patients do very well just eating right and staying active and having good social connection with people. But a lot of patients benefit from some kind of surgery for degenerative disc issues. So we do discectomies and we do disc replacements in that setting. And we do the disc replacements and discectomies both in the cervical and lumbar spine. And then sometimes a fusion is needed, like maybe there's some instability in the spine or the arthritis is particularly advanced, and we do a lot of fusions. Most of the fusions that we do are done at one level with a minimally invasive approach, which is like a one night in the hospital thing, and the recovery is a lot faster than it maybe used to be. Some of the fusions are big reconstructive surgeries that take quite a bit longer to heal. And I do some of those. There's some other surgeons in the area that are good at them as well. So other things in the spine, like occasionally we'll have a patient with a spinal cord tumor. We removed a spinal cord tumor just a few days ago. That happens from time to time. We also work with the pain doctors to do some spinal cord stimulation, which is a wonderful advance and is a little bit like a pacemaker for your back, which is treating pain in a completely different type of way. And it's nice because it's a reversible treatment and quite effective, but has a low risk. So those are the main things we do in the spine. The brain, I do not do vascular neurosurgery. There's a neurosurgeon in this community that does. There's a couple in the, more than a couple, probably a handful in the Salt Lake community that do vascular neurosurgery. That's particularly high risk and particularly subspecialized, and it's not within my scope of practice right now to do vascular, so like aneurysms, AVMs, those kinds of things. I do, however, do like head trauma and spine trauma, so patients that are in accidents and have head bleeds. There was a patient a couple weeks ago that fell off a ladder and required a very emergent craniotomy for a large epidural hematoma, which is like a arterial bleed inside of the head. We do brain tumors, particularly meningioma and glioblastoma, which are at the ends of the spectrums, right? Meningioma is slow growing and benign, and glioblastoma would be cancerous and aggressive. And then we do Chiari decompression. There's also a surgery for trigeminal neuralgia that is in the posterior fossa, both of those surgeries. So it's a pretty good variety, really.
Yeah. I've sent a few folks over. One was a really sad case. He had a sarcoma in his lower spine, had cauda equina syndrome, 17-year-old kid, super sad. He ended up dying a year and a half later. And then the other was just recent, breast cancer. She had vertigo that wasn't responding to like Dix-Hallpike Epley maneuvers. Mm-hmm. And in my clinic, and I said, well, something else is going on. So we neuroimaged her brain, and she had some Mets to her brain. And neurosurgery went in and debulked some of that. And so I think it's a neat skill set. You have very, I would say, high risk. I mean, you only have one of those things that you're operating on. A lot of people have 2 kidneys, they got 2 knees, there's some
margins. There are 2 frontal lobes, I suppose.
Okay, fair. But I think it's a neat line of work. How long is your average surgery, would you say?
That's an interesting question. It's probably an hour.
Yeah. Most common, would you say, are fusions?
The most common surgery, I would say the most common 3 or 4 surgeries, which are all pretty similar in how frequently we do them, would be cervical disc replacement, lumbar discectomy, and lumbar fusion.
I got it. When is so I see a lot of these folks, right? They're like, I'm like the first line of defense, right? And so they come to me, they've got some ridiculous symptoms, some neck pain shooting down their arm. My guideline, and you correct me if I'm wrong, but I'm watching this, I'm doing physical therapy, we're doing stretching techniques, strengthening techniques. I really like what you said about eat right, stay healthy, and social connections. And I thought, it's interesting to hear a neurosurgeon talk about biopsychosocial, wellness. But it's true. That is such a key part to that.
The food pyramid has had a bad rap, right? Maybe it's an upside down pyramid. Who knows?
Yeah.
But maybe we should think about the pyramid for musculoskeletal care. And the foundation of that pyramid has to be nutrition, exercise, and social connection, 100%. Those are the 3 factors, time and time again, that are correlated with longevity. Yeah. And any patient with any problem should always take a look at that foundation and work through improvement there. And people might think, well, it's not going to help. And I think, well, what if it made a 5% difference? Or what if it served the foundation for other treatments? If you neglect those things, your outcome from everything else is not going to be as good.
Yeah. I love that. It resonates with exactly what we do. When folks come in, we talk about all of those spaces and how they're doing in all those spaces and what we might do to kind of nudge them in good directions. I think pickleball is obviously the answer to the social part.
But pickleball, yeah. Actually, that's a really good point. When you can combine those 3 things or 2 of them into an activity, those are the best activities.
Totally.
For example, the best habit for my health that I currently have in my life is my wife and I, when the weather isn't super cold, go for a walk around our neighborhood at night. And just think about it. We are not on our phones. We are connecting with each other. We're talking to neighbors. And we're out walking. So we're getting exercise. And if you couple that with a nice family dinner, I mean, that's great.
Yeah.
And in our culture, we've eliminated that. Yeah. We don't sit down to family dinners as often. We don't go out for walks. we don't connect with people in real life anymore like we used to. And so it's no wonder we're horribly unhealthy as a society.
It's fascinating that you're linking that into neurosurgery because musculoskeletal health like very much plays into that whole equation. I'll tell you a quick story. I had a guy when I was in Moab. He's actually a miner, and he had a little spot in Jarbidge, which is north of Elko, Nevada, in the mountains up there, and he had a little mine up there. He would come see me. I took care of him for many years, and he must have been in his 90s.
Oh.
And his knees were bone on bone. Like, we would get x-rays once every couple of years, and his shoulders were bone on bone. His back was just fraught with arthritis. He walked with a little cane, and he never complained. He would come in, "How you doing?" "I'm doing fine, Dr. Sanders." I say, what are you taking for pain?" "I just take an aspirin once in a while."
Yeah.
And I'm like, if I could bottle that up and give it to my people, like, that is just, and I think he just kept moving. He just kept moving.
Yeah.
He stayed active. He had social connections with his family and friends, and he just stayed real active. Like, even towards that, he's like, "I'm going up to Jarbidge this weekend. I'm going to go mine for a while." I'm like, what does that
And that's
entail?
the big challenge, right? Is you have examples of people that have lived a healthy life. Maybe they're on a farm. Maybe they're out in the country. They have natural relationships with people, and they maybe and oftentimes eat a pretty good diet. And there's examples of social media influencers that are promoting that very kind of thing, but it almost doesn't feel like something that you and I could do, because we've got to hop in our cars and get on the freeway to go to work, or we have schedules that are plump full of activities all the time, or we're constantly getting bombarded with messages and emails.
Yeah.
And so it's like, how do we live that lifestyle? That's the question. And what are the things that make us go down and drift down into what most people seem to be doing nowadays, which is eating out, on their phones, and inactive?
Yeah. I only feel, I don't know, in the last 5 years maybe, I've been better at that. Our profession is very demanding, and and then you have all the things with society, and distractions and things, and disconnections and all those things. And I think it's very astute to make those connections and to see, where we're going. And I did a podcast called Balance, which is really good, talks about this space, and also did one called "It Turns Out the Amish Were Right," which talks about, like, maybe technology is not good for our families. And so, no, I'm with you in this space. What about, okay, let's talk about neck pain. Very, very common. People in their 30s or 40s, we're speaking of technology, right?
Yeah.
We're always down and forward.
Down.
And I'm constantly talking about pec stretching and strengthening posterior chain stuff and bringing the chin back. And I got like 10 exercises. I make videos about it. I give them to my patients all the time. Yeah. But it is a challenge. So okay, I've got neck pain. And it's hurting bad. And, I went to my family doc. He did some, I gave him the videos, I did the stretches, we're doing the things, and it's not getting better. I did physical therapy for a bit, and that helped a little bit for a time, but I went back to my old habits. And consistently strengthening posterior chain is just, it's not the beach muscles, they're not sexy, like nobody does that. So that would be like, upper posterior back and shoulders and stuff. And so at what point are we nudging toward you? So my guideline, and this, correct me if I'm wrong, is like, okay, you got radicular pain and you're getting some muscular involvement. Once that muscular involvement happens, I'm like sending them to you. Is that too late? Is it too early? Is it reasonable?
No, it's reasonable. We're always happy to see people.
Yeah.
And I think that people don't necessarily need to be on the brink of having to have major surgery because everything else has failed and it's a last resort. I don't think about it that way. It's really nice to get some x-rays and an MRI and to say, look, your spine actually looks pretty healthy. This is likely to resolve. And give them that reassurance versus looks like there's a couple of involved discs here, and you probably should spend some concerted effort to get this to settle back down. If it doesn't, there's some surgical options. And I think that perspective is maybe the right one.
Okay. Yeah, I like it. Same thing with low back.
Same with low back. Yeah.
Those are the most common. We see them all the time.
All the time.
Yeah.
And I think for all of us, we want to be movement generalists. We want to, so many of us are doing the same motions in the same set of steps over and over. And, the classic example of that is just looking down at a phone or sitting at a computer screen. So incorporating some good general movement into your routine is really helpful. Good nutrition and the social relationships. But at the same time, a recognition that some of these things happen, and a lot of it is genetic. And fortunately, there's very good options out there, good physical therapy things. The chiropractors can do a lot of great things. And then imaging is so good. You can really give a patient a good picture of what's going on and what they should be concerned about. And knowing that can help maybe motivate some behavioral change, but it also can help guide a comprehensive treatment plan, which is really good.
Yeah. Do you do anything with adenomas, like pituitary adenomas?
Yes.
Yeah.
Yes.
Are they always have to treat, or do you sometimes
most patients with a pituitary adenoma don't require any treatment.
Yeah.
But the pituitary is a very unique area in neurosurgery. It has very close relationship to endocrinology because some of the tumors produce a hormone, like Cushing's disease produces steroid cortisol hormones that cause all kinds of problems, and acromegaly or giantism, those kinds of things. Those are the minority of pituitary tumors. The main reason for pituitary surgery would be a hormone-producing tumor, unless it's a tumor producing prolactin, which is usually treated medically, or if the tumor's large and is causing peripheral vision loss because the pituitary gland is underneath the optic nerves, and the majority of tumors that go to surgery fall in that bucket. They're large tumors, and they're removed through the nose, and the pressure is alleviated reliably on the optic nerves.
Yeah, that's how I recently diagnosed a pituitary tumor, and we caught it through endocrine workup. Her hormones were just out of whack, and she's like late 30s. Like they should be purring along, and she had been having almost menopausal symptoms and stuff like that. And so, her LHFSH were basically zero. And
wow.
That's fascinating stuff. Well, awesome. It's safety tips and tricks for our community, for our people. Brain injury is a big deal.
So a lot of the safety things are cultural. Neighborhoods exist in pockets throughout the United States where everybody wears a helmet or nobody wears a helmet. So anything that we can do to set an example and promote a culture of safety, I think, is really good. Wear your seatbelt. Don't text and drive. Wear a helmet. Be cognizant of what you're doing. A lot of accidents have the possibility of being prevented. We see a lot of people getting rear-ended because they're on their phone in a car, and it's just not safe. And especially with our freeways being more congested, there's just a lot of unnecessary accidents because of distracted driving. That's probably the number one thing. Helmets are great. It's a cultural thing. If you go to the ski resorts, everybody wears a helmet. It's really unusual anymore at the ski resorts to see people not wear helmets. 20 years ago, very few people wore a helmet. So that's completely shifted. And yet we see kids out on bikes and razors and other kinds of two-wheeled and three-wheeled things where they could pretty easily take a stumble, and very few of them wear helmets. And so even my own kids sometimes will go out but it's cultural. They do it because everybody else is doing it.
Yeah, totally.
And so those are the main safety things, and just making them culturally accepted is the strategy.
Love it. And lastly, just concussions. Let's go there just briefly. Really, really common. I do a lot of sports medicine, and that was my undergrad. I was like an athletic trainer. Any advice in the concussion space, when to get help, and then kind of what to do about it?
Get help early and work with a competent caregiver with experience. I think the prognosis for concussion is good. I also think that working with somebody early in the process is also good. Our evolution on concussions is mirroring that of like a ankle sprain. It used to be that people would ice it and rest it and raise it and elevate it and compress it. And now we kind of more or less talk about just walking it off.
Just move. Yeah, move. Yeah.
Movement is good for healing. Cervical whiplash, same thing. It's really painful, and we want to restore functional movement as soon as possible. And with concussions, I think we want to get people back to functioning in an appropriate timeline. What becomes really tough is when it becomes chronic. Chronic neck problems, chronic headaches, and concussions are much, much more difficult. So seeking treatment early and getting right on it is the way to go, I think.
Yeah. You're right. Old sprains, like even grade 3 sprains, they used to like cast them.
Yeah.
I remember I had a really bad sprain in college, and they casted my foot. And I'm like, are you kidding me? I cut it off. It was a bad idea. But same thing, like old concussions, they used to put them in a dark room, not move them, very minimal stimulation. And now we're like, no, we need to not do that. Get them out, get them going. We'll often see like emotional changes and confusion and brain fog and difficulties concentrating, and that's okay. You go to that point again, where you go to the point of failure, and then rest for a bit, and then push again the next day, and we see way better outcomes with that, like in the primary care space, as opposed to the people that like turtle in and go to the room and no TV and no phones and all that. Like, oh,
yeah, all of medicine is that way now, or at least the recommendations are. We don't want people in the hospital for long periods of time. We really don't give people restrictions after spine surgery. We want them up and moving. We want them to be incrementally increasing activity. We want them to be mindful of their movement. But we want them to start walking as soon as they can.
Yeah.
And there's very little reason to keep people in some sort of prolonged bed rest or dark room, depending on the particular pathology involved. And I think concussion is the same.
Post-concussion syndrome, these like folks that maybe don't get better, a small percentage of the time, I in my experience, but do you have any solutions for those people, any neuro rehab stuff or anything like that in your practice here?
We don't do any specific work with concussion. Like I said, our primary job is whether the patients need surgery or not.
Okay.
Nobody needs surgery for a concussion, really. People do need surgery sometimes for head bleeds and things like that. There's some instances where a patient has had surgery for a traumatic brain injury, and we've done surgery, but they still need rehab and lots of therapy after. So I would say that with the chronic concussions and chronic brain kinds of things, revisiting physical therapy, and especially those that are trained in some of the specific exercises that can be done, it's really quite elegant and remarkable, the effectiveness of going and doing those kinds of programs.
Yeah, cool. Well, Dr. Edwards, thank you for your time today.
Yeah.
This was really fun, and I learned some cool stuff, and I hope our clients did as well, and our patients and our community. I really loved your holistic approach to neurosurgery. It's exactly what mine is in family medicine, and I think that was really refreshing to hear. And I really like that one of your main jobs was how to convince people not to have surgery. and that's really neat, and help keep them healthy and keep them moving, and that's really cool. Any thoughts or anything in closing?
No, this is great. I think patients should be part of their own care team. They should have access to the knowledge and the conversations that we are having in clinical medicine and feel connected to that. So I think it's wonderful that you do a podcast and get that kind of information out to the patient community and let everybody know what our thinking is. And I think that's quite empowering.
Yeah. Thank you. I make these little pieces of serenity wood for my clients and my patients. And so I wanted to give you one. This one is beech wood. And I just it's kind of grounding. It's like the opposite of a fidget toy.
Next time I'll bring it on the next podcast and I'll give much better answers.
It's really satisfying. I don't know what that is, but there's some grounding effect with the wood. You could smell it and hold it. And I sometimes, I'm way too into this, but I'll sit out in the morning and just like look at it in the sun, because it's like the grains of the wood, there's some magic there. It's beautiful and it's connecting and really cool.
I do have one funny story about that.
Okay, yeah.
So when we put in screws in the back with a minimally invasive approach, there's a tower that connects to the head of the screw that you put the set screw down through, because you have to get it to screw all the way down to the screw, but you can't see the screw anymore because it's buried, right? And so it's like having a screw or a nut that you have to screw all the way down. So we have a speed driver where one revolution on the speed driver is like 3 revolutions of the screwdriver. But the speed driver is like, you could spin it and it would spin for a long time and have this like really pleasant vibration. So we've got our own version of a
serenity
fidget toy. It grounds me in surgery is basically what I'm getting to.
That's amazing. That's amazing. Well, thank you. And thanks to our clients for tuning in today. I hope you learned some good stuff, and don't forget to like and subscribe.